The treaty covers approximately 250,000 acres, including the land that many of us now call home. We won't review the treaty, but the link will be provided here. We have two first-time presenters today, both tackling monoclonal antibody trials for the treatment of Alzheimer's dementia. First, Dr. Mercedes Lupo, PGY4 Geriatric Medicine resident. Mercedes has a keen interest in medical education and serves as our PGY4 resident representative on the RPC. Mercedes, welcome, a warm welcome, and please feel free to share your slides and start the presentation.
Okay, just confirming again, you're seeing the right view. Great, okay. So hi everyone, my name is Mercedes and I am a PGY4. Today I'll talk about a trial of Solanezumab in preclinical Alzheimer's disease, which it was a trial published in the New England Journal of Medicine in July of 2023. I have no conflicts of interest to declare. The objectives today are to go through the background behind the study, the methodology, the outline of the trial, and look at a critical appraisal of it, followed by conclusions and takeaways. There's evidence to suggest that amyloid positive but cognitively unimpaired older persons represent a preclinical Alzheimer's state, which is the case in about 20 to 40% of cognitively unimpaired older persons. Anti-amyloid therapy, as we know through monoclonal antibodies, are being tested in treating Alzheimer's dementia. Solanezumab is an immunoglobulin G1 monoclonal antibody that binds to the mid-domain of the amyloid beta monomer. And meta-analyses of low-dose solanezumab in Alzheimer's have been shown to slow clinical progression of Alzheimer's disease with mild dementia. So this trial examined whether solanezumab could have a similar effect in preclinical Alzheimer's. The study looked at the effect of solanezumab versus placebo on older adults across Canada, the US, Australia, those aged 65 to 85 with preclinical Alzheimer's disease, which I'll define in a subsequent slide, through changes in the preclinical Alzheimer's cognitive composite score, which I will also go through at a later slide, over 240 weeks or 4.5 years. This is the inclusion and exclusion criteria. So other than age, they looked at individuals who were living independently without a dementia diagnosis. They had an absence of cognitive impairment, which was characterized by a CDR score of 0, an MMSE score of greater than 25, and an LMDR of 6 to 18. They had a partner to provide collateral history, and they had elevated brain amyloid levels as assessed by PET. And then exclusion criteria was a long list, but sort of captured unstable medical conditions, altered laboratory work, and use of acetylcholinesterase inhibitors or memantine, which is important because the earlier trials of solanezumab did include individuals who were on these medications. They started with 6,763 participants to undergo screening, and 1,169 ultimately underwent randomization, 406 of which ultimately received the solanezumab and completed the trial, and 424 of which completed the trial and received placebo. The modified intention to treat population included 564 in the solanezumab group and 583 in the placebo group. They then did go on to do an open label extension phase where nearly 400 in each group continued on to receive solanezumab. The two groups, solanezumab and placebo, had similar baseline characteristics, including their mean PACC scores, which would become the primary endpoint, ApoE E4 carrier status, and amyloid burden on PET. However, though they tried to increase the representation of various groups, Black, Hispanic, and Latino identifying patients were underrepresented. Participants were randomly assigned in a 1-to-1 ratio to receive solanezumab or placebo and were stratified according to ApoE4 carrier status, years of education, and trial site. The initial dosing regimen was 400 milligrams IV every 4 weeks, but in 2017, this was increased to 1,600 milligrams IV every 4 weeks after the results of a completed phase 3 trial, the Expedition 3 trial, suggested that the dose of 400 milligrams was actually inadequate, and that was done in mild Alzheimer's dementia. And then this occurred when 970 patients had already been enrolled, but the double-blind phase of the trial was extended to 240 weeks to ensure that enough exposure to the higher dose was met. The primary endpoint was this change in PACC over 240 weeks. So PACC is a validated scale devised to measure amyloid-related cognitive decline in unimpaired populations in clinical trials. It looks at 4 components: the picture word list learning test, a paragraph recall test, timed executive function test, and global cognitive measure in the MMSE. And the secondary endpoints were the cognitive function index, the ADL prevention questionnaire, and the CDR sum of boxes, which essentially capture both subject and partner perspectives of functional outcomes as well as cognitive ones. And then they looked at imaging endpoints of amyloid PETs, volumetric MRIs, and tau PETs in a subgroup of participants. They aim for a sample size of 1,150 participants, assuming 30% attrition, to achieve 80% power in order to detect a between group difference of 0.53 to 0.57. And they had originally planned a mixed model repeated measures approach, which treated time categorically, but this trial was done between 2014 and 2022. So given there was a hiatus in dose administration and testing due to social distancing with the COVID pandemic, many visits were conducted later than their original dates. So the plan was amended to a days since baseline derived from examination dates. And this was all done before unblinding. And so they ended up with a constrained longitudinal data analysis using natural cubic splines of the primary endpoint, the PACC. In terms of the results here, the graphs on the right graphically depict the results for the modified intention to treat population. So this top graph here is the primary endpoint of the PACC, where higher scores indicate better cognitive performance. And so this showed a worsening of cognition with both placebo and trial drug. The Solanezumab group had a mean change from baseline in the PACC of -1.43 with a 95% confidence interval, and the placebo group had a mean change of -1.13. The difference was a difference of -0.3 with a p-value of 0.26, so indicating there was no significant between group differences, but a numerically greater decline in treatment group. Given the between group differences for the primary endpoint were not significant, the graphical testing scheme didn't allow for claims of significance for other endpoints. You can see a numerical decline in other secondary endpoints in graphs B, C, and D. And then looking at the bottom right, graph E, you can see a numerical, you can see an increase in the CDR, which would indicate as well cognitive worsening. The amyloid PET scan showed continued amyloid accumulation above baseline in both groups, numerically larger in the placebo, and the statistical significance there again was limited. The tau PET, which was done on 114 participants, showed similar increases, and then they had similar changes in volumetric MRI measures of the hippocampus and total gray matter between the groups. And they also looked at baseline amyloid levels and risk of cognitive and functional decline and risk of progression to AD, but were unable to draw statistical inference from this. With respect to adverse events, serious adverse events and overall events were similar between both groups in the type of adverse event and the incidence. For ARIA-E, in the Solanezumab group, it was 0.2 and placebo was 0.3, whereas in the ARIA-H, there was 29.2% in the treatment group and 32.8% in the placebo, so fairly similar between groups and a little bit less in the Solanezumab group. With respect to the critical appraisal of randomization, given the allocation sequence was random and concealed until participants were enrolled and assigned to interventions, in addition to having similar intervention groups, the overall risk of bias here was felt to be low. Participants, carers, and people delivering the interventions were not aware of participants assigned interventions during the trial, and they had a modified intention to treat analysis that was used to estimate the effect of assignment to intervention. And so therefore, again, here the risk of bias was felt to be low. But final PACC data was missing for 30.6% of participants in the Solanezumab group and 28.4% in the placebo group, which is felt to be high. And though the study mentions a sensitivity analysis, these are not presented in the main paper or appendix. Missing outcome data could depend on its true value, and that change in health status could have led to loss of follow-up or withdrawal. And there are some slight differences in the breakdown of groups with respect to missing data, and therefore the risk of bias in this section was felt to be high. In terms of measurement of the outcome, the method of measuring the outcome was appropriate. The PACC is a validated score for amyloid-related cognitive decline in unimpaired populations in clinical trials, and it's developed to be sensitive to changes in preclinical AD. The measurement was not likely to have differed between intervention group, as they had the same study schedule, and psychometrics administering the testing trained in this were also unaware of the trial group assignments and adverse events. And then finally, with selection of the reported result, the analysis plan, though it differed from the initial plan, was finalized before any unblinding occurred. And the reported results for the outcome domain corresponded to intended outcome measurements and intended analyses. But overall, given there was one domain with a high risk of bias, the overall study was felt to have a high risk of bias. So why did this not slow clinical progression? Well, the results were consistent with prior trials of symptomatic AD that have shown that substantial reduction in brain fibrillar amyloid toward normal is associated with slowed progression, in contrast to lesser reductions. And so this trial, though it slowed accumulation, it didn't actually reduce the fibrillar amyloid levels below baseline. And so why was there cognitive worsening? The authors thought that perhaps the significant dose increase by a factor of 4 may have actually led to severely depleting monomeric amyloid beta, and that perhaps the somewhat elusive amyloid protein is actually important and protective for brain health. And that was seen as well in the gamma secretase studies of semaglutide in 2013. So in conclusion, solanezumab here did not slow the progression of cognitive and functional decline in persons with preclinical Alzheimer's disease compared to placebo. Some of the limitations here would have been the risk of bias in the study population, not truly representing older persons at risk for cognitive decline. There's increased risk and burden of dementia among African American, Black, and Hispanic and Latino individuals compared with non-Hispanic white individuals, which this study didn't capture. Further studies can look at exploring dosing and possible effects on clinical and cognitive outcomes for solanezumab, as well as inclusion of more representative population. But ultimately, solanezumab results shouldn't necessarily act as a signal of the results of other monoclonal antibodies in a complex and incompletely understood pathway. Thank you, and these are the references here.
Thank you very much, Mercedes. A beautiful presentation, and as you mentioned to close, a result that goes against some of the other monoclonal antibodies that are generating a lot of interest in Canada recently. So I open it to the audience. Does anyone have any questions for Mercedes or comments? Go ahead, Gary.
Thank you very much, Mercedes. Nice presentation. I get just a comment. Clearly, the targeted amyloid matters. So we'll see with the next presentation. So one cannot presume that if they talk about an amyloid antibody, that it's necessarily targeting the same amyloid, and that clearly makes a difference. Just by way of question, this sample population had no cognitive impairment, and there are studies that have shown that there are individuals that have amyloid on their PET scans, but when followed over time, actually never develop dementia. So do you think when you target a cognitively intact population, did this study adequately consider other risk factors to try to narrow down the population to those most likely to progress? And with future studies of people with normal cognition, what would you be recommending?
Yes, I think they included some other risk factors, for example, vascular disease, but maybe future studies could sort of look at the outcome separated by some of those other risk factors to see if there's any differences between some of those.
Thank you. Go ahead, Natasha.
Hi, Mercedes, can you hear me?
Yes.
Okay. I thought it was interesting that that was wonderful, by the way. Well done. But I thought it was interesting they assumed a 30% attrition rate in their power calculation. I thought that was a high attrition rate. Is this a comparable attrition rate to like what the other trials of the monoclonals have seen?
Yeah, so it was a little bit higher. Some of the other, specifically with Solanezumab, some of the other attrition rates were in the 20s, but this was higher than I had seen in the earlier studies.
And do you have a sense of why that is? Was it just COVID, like the timing, or was this a particularly arduous trial?
There was a few related to COVID. Actually, in the overall number, it didn't seem like COVID was an overwhelming contribution to that. A lot of it was just labeled as unwilling to participate or continue on in the trial, but the actual reasons for that were not clear in the outline.
Thanks, Natasha. Thanks, Mercedes. If John Murata is on the line, he has experience participating in these trials and could inform on why it's so difficult to retain these study participants, to follow up with that question as well. Is John out there? No. And Mercedes, I have one last question. It's interesting for a clinician who is not familiar or intimately familiar with these primary outcome scales, because they're not readily available or they're not available for clinical use. Do you know what the minimally clinically important difference on that scale would be and how a clinician would interpret it? Because this outcome is different than the CDR sum of boxes that a lot of the other monoclonals reported as their primary outcome. And I imagine in the next presentation, we might be learning about what an important difference is on the more common primary outcome.
I'd have to look back at the exact difference for that to be clinically relevant.
And the last question, and Gary, correct me if I'm wrong, a negative randomized control trial, and you may have touched on it, Mercedes, sometimes is a power issue. Do you think that this was a inadequate power to prove a difference in the primary outcome?
I think that they were able to meet the number that they were hoping for in order to get the sufficient power that they had specified initially. So I don't know if it was necessarily that.
I think one of the, interesting findings, again, we can compare it with the other monoclonals against amyloid, is they did not clear the brain amyloid. So I'm guessing that they're swimming upstream with this particular product moving forward. I can't see that there's going to be a lot of optimism to try to continue, given that they clearly did not eliminate the brain amyloid.
And I know
Thank you.
studies have talked about sort of a combination drug that might need to tackle two parts of the pathway. And so whether this is useful with something else that is targeting something a little bit more downstream as well.
Great, thank you. Any other questions for Mercedes or comments to go into the chat box? If not, we are at time to move on to our second presentation of the morning. Thank you, Natasha, for the applause. Our next presentation comes from Dr. Nitzan Segal, a geriatric medicine rehabilitation fellow at UHN Sinai. Nitzan joined the fellowship program in July and is studying and coming to us from Israel. A warm welcome to you, Dr. Segal. Please feel free to share your presentation and begin.
Thank you. Just a second.
Nitzan, I'm happy to help if technical issues.
Mhm.
I think you're probably sharing the wrong.
Yeah.
You're sharing the Zoom window instead of the PowerPoint slide, and so
Yeah,
when you
let's try again. Okay,
Sure.
okay. Yeah.
There we go.
Okay.
So oh, perfect.
Okay.
That's great.
Technical
Yeah,
problems. Yeah.
yeah. So we see the slide and we hear you well.
Thank you for your patience.
Yeah.
Yeah. Good morning, everyone. Today I will present the Lecanemab study named Lecanemab Early Alzheimer's Disease, which was published in the New England Journal of Medicine in January 2023. This study named Clarity AD provide analysis for lecanemab rose in the early stage of Alzheimer's disease. I have no conflict of interest. The presentation objectives will be the anti-amyloid therapy in Alzheimer's disease, analysis of the study, lecanemab safety and efficacy, critical appraisal, an editorial review of the study, and in the end, comparison between the other anti-amyloid therapies. Alzheimer's disease pathology involve amyloid beta plaque. Recent studies suggest that the removal of amyloid plaque will play a role in slowing the progression of Alzheimer's disease. These plaque, which are accumulation of protein fragments, are considered hallmark of the disease. Drawing attention to the advancement in this area, the antibody aducanumab received attention when it got accelerated approval from the FDA. This was a significant step showing the potential of anti-amyloid antibodies in treatment of strategies. Lecanemab treatment saw approval from the FDA in January 6, 2023, under the accelerated approval pathway of early stage Alzheimer's disease. And by July of the same year, it received the full approval. Lecanemab is a humanized monoclonal antibody with high affinity to soluble amyloid beta, specifically the protofibrils. Protofibrils are large soluble aggregates of amyloid beta filaments. These protofibrils leading to mature amyloid fibrils commonly associated with the disease. A phase 2b trial was conducted involving 854 patients diagnosed with early Alzheimer's disease, showed dose and time dependence in clearance of amyloid using lecanemab. This slide visualized the stages of amyloid beta aggregation, starting with simple monomers on the left, progressing to oligomers and protofibrils in the center, which are the neurotoxic form, and mature fibrils in the right. Lecanemab bind to the protofibrils, and this makes it effective against the neurotoxic form of amyloid beta. The Clarity AD phase 3 trial aimed to evaluate the safety and efficacy of lecanemab in individuals with early stage Alzheimer's disease. In an 18-month multi-center double-blind trial, participants were randomized to get intravenous lecanemab, 10 milligrams to kilogram every 2 weeks, or placebo. Let's look at the study population. Participants were stratified based on clinical subgroup, including MCI due to Alzheimer's disease or mild Alzheimer, current Alzheimer medication, acetylcholinesterase inhibitors, memantine, or both, and the genetic factor of ApoE4 allele status. The study also accounted for geographic diversity to mitigate regional variation effect. The trial had the Helsinki approval, and all participants provided written informed consent. Inclusion criteria included participants aged 50 to 90 with either mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's disease. Confirmed amyloid pathology was determined by PET or CSF, measured amyloid beta, and all participants had impairment in episodic memory. This slide illustrates the study design. As you can see, the patient population included individuals with early Alzheimer's disease or MCA due to Alzheimer's disease, who were confirmed to be amyloid positive. They had Mini-Mental score range from 22 to 30 and demonstrated memory impairment, which was measured with the Wechsler Memory Scale. Patients were randomized into 1-to-1 ratio, received either Lecanemab or placebo. The study followed them for 18 months and included an open label extension phase. This is the Wechsler Memory Scale 4. It's a neuropsychological test designed to measure different memory functions. 5 index scores include auditory memory, visual work memory, immediate memory, and delayed memory. The primary endpoint was the change in CDR, clinical dementia rating sum boxes, score from baseline after 18 months. The CDR sum of boxes is a tool we use to quantify the severity of symptoms of dementia, evaluated patient level of cognitive and functional impairment. It's based on interview with both participants and their caregivers, assessing 6 domains: memory, orientation, judgment and problem solving, community affair, home and hobbies, and personal care. Each domain is scored from 0 to 3, with higher score indicate more significant impairment. The total score can range from 0 to 18, and we are particularly focusing on score from 0.5 to 6 to identify early Alzheimer's disease. This is the CDR sum of boxes scale. This study evaluates several secondary endpoints. First was the amyloid burden as seen by PET-CT measured in centiloids. The second score from the ADAS-Cog 14, which is a cognitive subscale for the Alzheimer's disease assessment scale. This 14-component test measures various cognitive ability ranging from 0 to 19. Higher score on this scale indicate more severe cognitive decline. The Alzheimer's disease compression score, or the AD-COMS, is a combined score from tests like ADAS-Cog, Mini-Mental, and CDR. This helps to spot early Alzheimer's disease, especially memory change, in scores from 0 to 1.97, with higher values indicate worse cognitive impairment. And lastly, the AD-CS-MCI-ADL score is the ADL score for mild cognitive impairment, which range from 0 to 53, with lower score showing greater functional impairment. The statistical analysis of the study. First, the efficacy of the treatment was analyzed using the intention to treat population. This includes participants who were randomly assigned to receive at least 1 dose of the treatment or placebo and had a baseline and at least 1 follow-up efficacy measurement. Second, the safety population, which include individuals who receive at least 1 dose of the treatment or placebo. Additionally, they watch for ARIA, or amyloid-related imaging abnormalities, with MRI scan at several points during the trial and in a follow-up visit 3 months after the study ended. The primary analysis was performed without imputation of missing value. And in the statistical analysis, they use a mixed model for repetitive measurements. It is important to note that this secondary endpoint will only be considered if the primary endpoint shows significance. And each test was performed with an alpha level of 0.05. A total of 5,967 persons were screened and 1,795 underwent randomization. 898 were assigned to receive lecanemab and 897 to receive placebo. This was conducted at 235 sites in North America, Europe, and Asia from March 2019 through March 2021. Table 1 represents the study population. The baseline features of both placebo and lecanemab groups are similar and well balanced. The average age of participants was around 71 years, and the majority were identified as white. There was an underrepresentation of Black individual and overrepresentation of Hispanic individual in the United States. Baseline CDR-SB were 3.22 for the placebo group and 3.17 for the lecanemab group. Baseline measurements show that the amyloid burden of PET-CT scan, it's here, was 75 for the placebo group and 77 for the lecanemab group. This was about 30 centiloid, which is the level in which participants are considered to have elevated brain amyloid level. Primary endpoint, CDR-SB score. This graph compares the progression of disease in participants receiving lecanemab versus those receiving the placebo group after an 18-month period. The y-axis shows the change in CDR-SB score, and the x-axis represents time in months. The orange graph, the orange line is lecanemab group, and the blue line is the placebo group. Mean change of CDR-SB from baseline at 18 months was 1.21 for lecanemab and 1.66 for the placebo group. Lecanemab treatment resulted in reduction of clinical decline in the CDR-SB compared with the placebo group at 18 months by 0.45, representing a 27% slowing of decline. This was highly significant result with confident interval between 0.67 to 0.23, as you can see here. In the amyloid PET secondary endpoint, treatment with lecanemab showed statistically significant reduction in amyloid plaque burden at all time points, starting at 3 months. Mean change in centiloid at 18 months was minus 55.5 for lecanemab and 3.6 for the placebo group. Mean difference was minus 59.1 with statistically significant p-value lower than 0.01. Lecanemab also slowed decline in cognitive function on the ADAS-Cog14 by 1.44 at 18 months, representing a 26% of slowing of decline, which was statistically significant as well, as you can see here with the p-value and confidence interval. In terms of secondary endpoint, assessing the ADAS-COM scale, which went from 0 to 1.97, the mean difference in AD-COMS score between the lecanemab group and the placebo group was 0.05. The difference was 95% confident interval from 0.07 to 0.027. The graphs show a clear separation in the trajectories in the two groups over the 18-month period, with the lecanemab group experiencing slow progression by the disease, specifically by 24% at 18 months, as you can see here. Lecanemab slowed decline in ADL with the ADCS-MCI-ADL score by 37% and 18 months, and this was also statistically significant. This table displays the primary and secondary endpoint. As demonstrated, all results are statistically significant. During the study period, death occurred in 0.7% of participants in the lecanemab group and 0.8% in the placebo group. No deaths were considered by the investigator to be related to the lecanemab or occurred with ARIA. Treatment emergent adverse event occurred in 88.9% of participants in the lecanemab group and 81.9% in placebo group. Treatment emergent adverse event leading to drug withdrawal occurred in 6.9% and 2.9% of participants in lecanemab and placebo group, respectively. The most common adverse event in the lecanemab group were infusion reaction. In lecanemab, 26.4% and placebo group 7.4%. Serious adverse events were experienced by 14% of the participants in the lecanemab group and 11% in participants of the placebo group. The most commonly reported serious adverse events were infusion-related reaction, ARIA-E, atrial fibrillation, syncope, and angina pectoris. ARIA-E is a amyloid-related imaging abnormality with edema, occurred in 12.6% in lecanemab and 1.7% in the placebo group. ARIA-E events were largely mild to moderate radiographically, asymptomatic, occurred within the first 3 months of treatment, and resolved within 4 months of detection. Among the 2.8% of lecanemab-treated subjects with symptomatic ARIA-E, the most common reported symptoms were headache, visual disturbance, and confusion. ARIA-H is a amyloid-related imaging abnormality with combined cerebral microhemorrhage, cerebral macrohemorrhage, and superficial siderosis. Was found in 17.3% of lecanemab group and 9% of the placebo group. The incidence of symptomatic ARIA-H was 0.7% in lecanemab group and 0.2% in placebo. ARIA-H that occurred with ARIA-E tend to occur earlier, within 6 months. Isolated ARIA-H occurred throughout the trial. ARIA-E and ARIA-H were less common in ApoE non-carrier versus carrier, with higher frequency in ApoE homozygote than in ApoE heterozygote. After 18 months of the treatment, there are notable outcomes. There was a smaller increase in the CDR-SB score of participants treated with lecanemab compared to those given placebo. Additionally, the secondary clinical endpoint showed similar trends, supporting the primary finding. Regarding amyloid level, the average in the lecanemab group was 22.91 centiloids after 18 months, which is below the threshold typically associated with Alzheimer's disease, which is 30. Critical analysis. This was a strength-blinded randomized trial that was conducted with the intention to treat to analyze. The trial did not have a significant dropout rate, and this was similar in both the treatment and control group. Overall, this was a well-designed and random trial. The trial demonstrated significant difference according to all measurements of cognition, function, and significant reduction in amyloid burden in PET scan. As with any clinical study, it's important to acknowledge a certain limitation that may have impacted the result. The treatment duration was only 18 months, which may not be long enough to fully understand the long-term effects of the drug. Conducted during the COVID-19 pandemic, the trial faced challenges like missed dose, delayed assessment, and other disruption due to illnesses. The dropout rate was 17.2%. Despite these challenges, a sensitive analysis showed that the impact of missing dose did not change the primary endpoint finding significance. The occurrence of ARIA could have influenced the awareness of participant and investigator regarding which group they were in. And lastly, a definition of clinical meaningful effect of the primary endpoint, the CDR-SB score, has not been established yet, and we will elaborate more of that. In an editorial commentary on the study published in The Lancet, several points were brought to attention. The 0.45 difference in the CDR-SB score, although statistically significant, raised the question of clinical meaningfulness given the scale of 18 points range. To put this in context, a 2019 study indicated the minimal clinical importance difference of the CDR-SB scale for those with mild cognitive impairment due to Alzheimer's disease was around 0.98. And it's even higher for those with mild Alzheimer's disease at 1.63. The editorial also points out a significant challenge for health system in providing lecanemab treatment widely. Limited availability of PET scan, which are needed to identify the right patient for the treatment, a lack of trained staff to handle bi-weekly infusion of the medication, and the need for regular MRI scan to check out for ARIA in patients receiving the treatment. The FDA has granted a traditional approval for lecanemab in July 2023. The FDA advised that physicians should use caution when prescribing lecanemab to patients with anticoagulant medications or those with high risk for intracerebral hemorrhage, and recommended to test for ApoE status before starting lecanemab to assess the risk for ARIA. The optimal duration of therapy also was unclear. There have been patient deaths associated with lecanemab use within the Clarity AD open label extension and with the context of exposure to anticoagulant therapy. And the Health Canada accepted the drug for review in May 2020. This slide presents the comparison between the 3 anti-amyloid therapies for Alzheimer's disease: aducanumab, lecanemab, and donanemab. In 2021, the FDA granted accelerated approval for aducanumab. In January 2023, lecanemab received accelerated approval from the FDA, and in July 2023, it received full FDA approval. And donanemab is waiting for FDA. We review some of the key features of the treatments and studies, but it's important to know that differences in the study design limit the direct comparison. The drug share the target of amyloid beta and the plaque reduction observed in a PET-CT, but they differ in the specific target of the amyloid. Aducanumab had a 76-week trial period with 1,638 participants in the eMERGE and 1,647 in the ENGAGE study. Lecanemab's phase 3 trial lasted 18 months with 1,797 participants, and donanemab also had an 18-month phase 3 trial with 1,736 participants. Aducanumab and donanemab treatment were given intravenous every 4 weeks, while lecanemab is given every 2 weeks. Aducanumab showed a 22% reduction in the CDR-SB in the EMERGE trial, but the ENGAGE trial did not meet the primary endpoint. Aducanumab was associated with 35% incidence of ARIA-E. Lecanemab demonstrated a 27% slowing of decline in the CDR-SB with a lower ARIA-E at 12.5. The phase 3 trial of donanemab used the IARS scale. This is the Integrate Alzheimer's Disease Rating Scale, which was developed by Lilly Company. The scale combined the ADAS-Cog13 and function scale Alzheimer's disease and the ADAS-Cog14 and the ADCS-IADL. Sorry. The scale combined two scale, the ADAS-Cog13 and the ADCS-IADL scale. Donanemab resulted in a 35% lower decline of the IADRS and 39% slower decline in the CDR-SB, which was the secondary endpoint for the combined population, with an ARIA-E incidence of 24%. Again, it's important to remember that we cannot compare the data directly due to differences in the study design. Importantly, drugs like aducanumab, lecanemab, and donanemab do not cure Alzheimer's disease. They can't stop or reverse the cognitive impairment. And patients must be aware that these drugs are appropriate for only some of the population with Alzheimer's disease and not everyone. In patients with early Alzheimer's disease, the treatment of lecanemab showed reduction in brain amyloid levels and was associated with moderate slowing of cognitive and functional decline compared with those with placebo. Lecanemab is the first drug specifically targeted to amyloid to be fully approved by the FDA. Like first treatment in other medical fields, it may pave the way for future more effective drugs. It's important to carefully consider the potential side effects when setting treatment goals and to weigh the risk and benefits with the patients. Thank you.
Thank you very much, Nitzan, for a beautiful presentation as well. Very well articulated, especially for your first time presentation. That was great. Thank you. The hands are going up quickly. I'm not sure if Michael or Barry was first, but Barry, you're closer to my icon, so go ahead, Barry.
I just wanted to say how great the presentations were. Just when I think residents can't get any better, they do. But I just want to remind people that when you see these impressive relative risk reductions or changes in any kind of study, go to the absolute change. For the donanemab study, there was significant improvement, but when we're talking about a difference of 4 and 140 plus unit scale, even though it looks dramatic for the relative risk reduction, it's hard to know what that really means in the absolute risk reduction. So I always remember that the investigators tend to trumpet those because they look more impressive than the absolute risk reductions.
Thank you.
Thank you.
Go ahead, Michael. You're still on mute. Just take a moment to unmute your microphone.
Yeah. I want to congratulate the presenters. They're really very good presentations on an area that's really hot in the media. I'm finding that everybody I now see in the clinic I do asks about it. I actually had an Uber driver tell me recently, hey, I heard there's a cure for Alzheimer's. So you can see how the media takes evidence and turns it into, I don't know, pablum. The only thing I could compare this to is chemotherapy. And having been through chemotherapy, and anybody else who has, it's quite onerous, but at least you sort of know what you're doing. In other words, you're trying to eliminate whatever the disease is, hopefully once and for all, or at least receive a long remission. I think at this point, to use this clinically in a wide scale presents too many problems to make it highly acceptable to populations, because it isn't clear how long you're going to have to take it for and what the markers will be to say you've had enough and for how long. And with Nitzan, I think this is really the beginning of probably a pathway that those of us who've watched the development of medicine have seen, where new drugs come out and eventually an intravenous drug becomes an oral drug and follow-up becomes a blood test rather than a complicated set of scans. Thanks a lot for your presentations.
Thank you.
Thank you. Go ahead, Gary.
Nitzan, thank you very much for the presentation. I'm going to hand the challenge over to Natasha, because I think this is a good example where a good economic analysis will help, at least in the thinking. Because when the things that need to be considered here, as Nitzan pointed out from the editorial, the infrastructure that will need to be developed to support doing this, increasing availability of MRI, infusion centers, having more access to LPs, at least if we don't have PET scans, to establish presence of amyloid, careful monitoring of these patients, cost of medication, which is in the neighborhood of $35,000 US a year. So, trying to take all these things into account, the incremental benefit, and as Barry raised, like how significant clinically is that incremental benefit? For example, might it have impacts on time to long-term care, which is there's a cost involved and obviously an outcome that people are not excited about. So there's a lot of things that need to be considered. And then in economic analysis, we talk about opportunity cost. If we put all of these dollars to support providing these treatments to the growing populations with Alzheimer's disease, what things will we not be able to pay for? So what is that opportunity cost if we're going to do this? So I do think an excellent quality economic analysis that tries to take all these things into account allows us to think about it in a slightly different way than, as Michael said, the media hype that gets translated to the general population that tends to think these treatments offer something beyond what they actually offer.
Thank you, Gary. I can also echo a little bit of what Michael touched on. Sunnybrook is surrounded by a patient population that is, or a catchment area that's well heeled. And I had a patient in clinic ask me, they have unlimited resources, whether they should travel to the United States, Buffalo, once a month for the treatment. And Nitzan, I wonder how you would respond to that individual.
I think, like most things in medicine, there isn't only one true answer for that. And like I wrote in the, like I said in the last slide, we need to weigh the risk and benefit. And like the other drugs for Alzheimer's disease, it won't stop the disease and won't take it back. It may decrease the progression. And I think that as long as the patient understands the goals of care and the risk and benefit, they can do shared decision with the physician. Other point that I want to maybe just to think about it in another way, just for us as the physician to discuss, not with the patient. I think when we saw treatment for cancer for the first time. Sometimes they were only also very expensive, and sometimes they also gave only few months of hope or of quality of life, not even survival. And we did appreciate that in certain circumstances. I think that here we can do some kind of comparison to dementia as well.
Thank you. Thank you, Barry, for your comment too. Toronto Western is planning a Lecanemab clinic. That's interesting. We have a couple more minutes. Any comment? I was not able to join the CCD a couple of weeks ago, but if anyone was at that meeting and has a few comments to share, that would be nice in the last moment.
I think Sandra Black made the comment that even the protocols are not good enough when it comes to the microbleeds. And she's now doing special protocol MRIs before to see if they have more than 4 microbleeds, which she thinks will eliminate people from trying these things. So it's ever more complicated. And as Michael said, until we have better screening tests, we really can't make this a population-wide approach.
Thank you. And comment, very nice to hear from Marisa in the chat box. Many more patients have combined vascular and amyloid disease. Are they eligible? And Nitzan, wonder if you have a comment.
They didn't write specific about that, and in the FDA's website, they did elaborate the chance to measure the risk of brain bleed before, but it's not an absolute contraindication. So I guess it's kind of the things that will be, the protocol would get better in the future.
Right. Thank you. So that brings us to the end of this November Journal Club session. I want to thank both our presenters again for fabulous presentations, first-time presentations at this forum. By way of announcements, the evaluation link should have been distributed to your inbox a few minutes ago. And also as a plug for Dr. Gary Nagley's Driving and Dementia Roadmap, I'm going to include a link in the chat box for the e-learning module study. And if you are interested in participating in that e-learning module, the Dementia and Driving Roadmap, that is the link to do so. Thank you all again for joining. Have a wonderful Friday and weekend.